I am thrilled to be here just because what you all are doing in practice, focusing on details, is a spiritual truth of our country.
You know, we can be Democrats and Republicans, but most Americans are patriots.
For over a decade now, good ideas have emanated from the VPC.
Thank you for convening this very impressive group of thought leaders.
Your organization has brought together leaders from across our society to advocate for common sense solutions to our most challenging problems.
Because if it's bipartisan, it's much more likely to pass.
When you have people philosophically and ideologically in two different worlds, and they put them together on a committee, that committee usually is not very productive. Once we get staffs blending, and John and I, they know that the members are friends and we talk, things can happen.
Thank you, Anand, for that introduction, and to the BPC for its important efforts.
Thank the Bipartisan Policy Center. You guys are great.
We all have bipartisan responsibilities to this nation to defend principles that have long made America the beacon of hope.
It's going to take all of us to try to turn down the temperature and really focus on what unites.
Welcome, and thanks for joining the Bipartisan Policy Center for the release of our report, Next Steps, Improving the Medicaid Buy-In for Workers with Disabilities. I'm Marilyn Serafini. I am Executive Director for the Health Program here at BPC. For over a decade, BPC's health program has developed and advanced recommendations to improve long-term care for individuals with complex needs. Today, BPC is releasing new policy recommendations that we believe will increase employment opportunities for Medicaid beneficiaries with disabilities. In the late 1990s, Congress passed two bipartisan laws, the Balanced Budget Act of 1997 and the Ticket to Work and Work Incentives Improvement Act of 1999. Both laws allowed state Medicaid programs to cover working adults with disabilities, and these people would otherwise earn too much to qualify for Medicaid. I'm happy to say that 46 states have taken up this option and established Medicaid Buy-In for Workers with Disabilities programs. These programs have allowed more than 400,000 individuals with disabilities to work while continuing to have access to Medicaid's services, such as home and community-based services. These are unique services that many people with disabilities rely on to live independently and work. However, we have found that many states have problems administering these programs, and those with disabilities have challenges accessing the buy-in programs. BPC's new report today includes specific actions that the next Congress, the Biden administration, and states could take to optimize these programs to benefit those living with disabilities who want to work. Building on BPC's January 2021 report, our new report includes federal policy recommendations to codify the Medicaid Buy-In for Workers with Disabilities eligibility groups and issue clarifying guidance. Enhance consumer outreach and interagency coordination. And third, support better data collection and technical assistance. On behalf of BPC, I'd very much like to thank the Robert Wood Johnson Foundation for its generous support of BPC, including its support for this report and event. I also want to thank Lisa Haratunian. She's Associate Director of BPC's Health Program. Lisa and her team have devoted significant time and energy to this project, and Lisa will be moderating our panel discussion today. Before turning this over to Kathy Hempstead of Robert Wood Johnson Foundation, who is going to provide some welcoming remarks, let me wish all of you and yours a joyous holiday season and a healthy new year. Kathy, I'll turn it over to you.
And hello, everybody. And I'm really happy to be here today at this event. And I'm looking forward to our session on next steps, how we go forward to improve the Medicaid buy-in for workers with disabilities. A year ago, BPC released the report that talked about ways to improve opportunities for people with disabilities who wanted to work and focused on the barriers experienced by Medicaid beneficiaries. And a focus of that report was on the buy-in, which is designed to let states cover working people with disabilities so they can work and retain their Medicaid coverage or use their coverage to access wraparound services. And as Marilyn noted, almost every state is using some version of this option. And over the past several decades, hundreds of thousands of people have been facilitated and participating in the labor force because of this option. But as the report noted at the time, this buy-in option is administratively complex and has been underutilized, meaning that people who could be working are not receiving the benefits of the buy-in. So today we're going to hear these recommendations that are designed to help this program work better and allow it to help more people. And as Marilyn noted, there's sort of three main recommendations and a lot of sort of subcategories of each that we're going to take up in the panel discussion. But first is to improve guidance around flexibility so states can understand what the options are. Another is to communicate better to consumers and people that work with or in families of people with disabilities so that people understand the option and take advantage of it to improve take-up. And finally, improve our measurement of what works and what doesn't work about this program, permit more technical assistance and state-to-state learning opportunities so that states can figure out what are the best ways to serve this population. There are so many barriers to employment for individuals with disabilities. And, the report does a nice job of talking about how the unemployment rate for those with disabilities is twice that for those without disabilities. But many of these barriers can be overcome with the appropriate health and social supports. And that's really important. And that will lead to increased income and improved quality of life for millions if we really take advantage of these opportunities. I think the importance of Medicaid for workers with disabilities is sort of a specific example of a more general point that we really care a lot about at the foundation. That coverage supports work, not the other way around. We don't work to get our benefits, but having health insurance and access to care allows us to work. And expanding coverage makes it easier across the board for everyone to be able to work and be productive. And that's one of the things that's been demonstrated again and again in some really strong, well-designed studies of the employment benefits of the ACA Medicaid expansions. So I think some of the conversations that we have about work requirements being a good idea for Medicaid really have things backwards, and that we really need to be covered so that we can work. And what's true for populations with disabilities is generally true. And I'm sure I mentioned this last year, but I'm going to mention it again, that I have a personal connection to this issue. And I really care very deeply about it because one of my sons has a disability and is a Medicaid beneficiary and has a job that he enjoys and can do well, thanks to Medicaid. He requires a lot of supports and special services, not just to get to work, but also to succeed there. And they're provided through the Medicaid program. And, on a little bit of a downbeat note, he was laid off very recently because the hotel where he works is experiencing a slowdown. And even though he doesn't understand anything about money or why, the economic aspects of that, his job was so important to him. And he was so upset that he continued to put on his uniform and sort of try to go to work on the days that he thought he was supposed to be working because it means that much to him. So I certainly hope that he's able to get back to work soon because he really misses it. And I'm keenly aware of the importance of the Medicaid program in supporting people with disabilities and providing them with the services that they need so that they can be productive at work. And again, I'll just close by saying what's true for people with disabilities is true for all of us. When we're healthy and our needs for healthcare are met, then we're better able to work and be productive. And we don't all have the same needs, but almost all of us are able to work if we get the right supports. So I echo Marilyn's thanks to the great team at BPC, and I'll hand it off to Lisa now. Looking forward to the event. Thank you.
Thank you, Kathy, and to the Robert Wood Johnson Foundation. And a big thank you to all of our viewers tuning in today. My name is Lisa Haratunian, and I'm Associate Director for the Health Program at BPC. Today, I'm joined by 4 panelists who together will bring a range of perspectives and valuable expertise to our discussion on improving access to Medicaid buy-in for workers with disabilities programs. As we begin the panel discussion, I'll first introduce each of our speakers, and then we'll dive into some questions. Toward the end of the panel discussion, we will respond to some audience questions, so we encourage all of our viewers to submit their own questions throughout the panel discussion using live chat on YouTube or on Twitter by using hashtag BPCLive. Now, the first panelist that I would like to introduce and welcome is Annette Shea. Annette is currently an independent consultant at Annette Shea Consulting. She's a subject matter expert on Medicaid Buy-In for Workers with Disabilities programs and a consultant to BPC. Her previous work at the U.S. Department of Health and Human Services and at the Centers for Medicare and Medicaid Services included a focus on Medicaid Buy-In for Workers with Disabilities programs. Welcome, Annette. Next, I would like to welcome Henry Claypool. Henry is the Policy Director at the Community Living Policy Center at Brandeis University and a consultant with BPC. He is also former Director of the U.S. Department of Health and Human Services Office on Disability and a founding Principal Deputy Administrator of the Administration for Community Living. Next, I would like to welcome Nancy Scott. Nancy is the current Working Healthy Director at Kansas Department of Health and Environment in the Division of Healthcare Finance. This department is responsible for purchasing health services for children, pregnant women, people with disabilities, the aged, and the elderly through the Medicaid program, the Children's Health Insurance Program, and the state-funded Medicaid program. Today is also Nancy's last day with the department before she enters retirement, and we're very appreciative that she's spending her last day with us. So congratulations, Nancy, and welcome. Next, and finally, I would like to welcome Brittany Hernandez-Wilson. Brittany is currently the Equity and Justice Director at the ARC Minnesota, an organization that provides personalized information, navigation, and referrals on disability issues and systems throughout the lifespan of people with intellectual and developmental disabilities. Brittany also brings her perspective as a participant in Minnesota's Medicaid Buy-In for Workers with Disabilities program. So thank you to each of our panelists for joining us today to talk about improving the Medicaid Buy-In for Workers with Disabilities programs. Today, you'll hear our panelists talk about, first, the current landscape and the value of these Medicaid Buy-In for Workers with Disabilities programs. Second, some barriers to states adopting or optimizing their programs. And third, federal policy reforms that would help to address those challenges. Also, to support accessibility of this panel discussion for audiences with visual impairment, our panelists may provide a brief description of their physical appearance before answering their first question. For example, I'm a Caucasian Armenian female in my 30s with blonde hair, and I'm wearing a black blazer. All right, let's now get started, and let's talk about what the Medicaid Buy-In for Workers with Disabilities programs are and their impact on beneficiaries and states. This first question is for Henry. Henry, what are the Medicaid Buy-In for Workers with Disabilities eligibility groups, and how do state programs covering those eligibility groups reduce barriers to employment for people with disabilities?
Thanks, Lisa. And I'm Henry Claypool, as you know. I am a white male with brown and gray hair. I'm wearing glasses and also wearing a black and white sweater since it's a little cold in my office today. First, before getting into the specifics of the buy-in programs, I just want to remind the audience that this population of people with disabilities has to meet a very stringent definition of disability that's used in the Social Security Act programs, including Medicaid. So the Medicaid buy-in programs allow states to raise limits on the amount of earned income and the assets that people can maintain so that they can stay enrolled in the Medicaid program. And those are just really important and essential information that we want the audience to take with it today. Congress created these eligibility groups in the late 90s, and they were passed, as you heard earlier in the introduction, in two different laws. The Balanced Budget Act of 1997 and the Ticket to Work and Work Incentives Improvements Act of 99. Both of these gave states an option to create a Medicaid buy-in, but there's a little bit of difference, and I wanted to just quickly touch on that. As we saw in the Balanced Budget Act Medicaid buy-in program, it was really a statutory reference that's quite brief. And it really largely mentions that states will have an income cap on participation of the program at 250% of poverty. But there isn't a great deal of definition in the statutory language in that provision, which leads us to 1999, when Congress passed the Ticket to Work Act. And it included in it a Medicaid buy-in that had a little more substantial eligibility criteria. It introduced age limits where there weren't really any with the BBA authority. There's a definition of work that was included in this buy-in group. It allowed for higher incomes, and it also developed kind of a graduated premium structure for states that chose to impose a premium structure on participants. And there is also a second buy-in authority in the Ticket to Work Act. And it's really largely, it's referenced as the medically improved group. And so states haven't used this very much, and I don't think we'll go into detail on that approach today. But I'd leave you with a real clear message that Medicaid's role here is essential, and that for many of the population that rely on it, disabled people that rely on Medicaid, HCBS is essential to them being able to live a meaningful life and pursue anything like employment opportunities. So with that, I think I need to turn it back to Lisa. Thank you.
Thank you for that helpful background, Henry. This next question is going to be for Brittany. Brittany, how does being an enrollee in Minnesota's Medicaid Buy-In program, which is called Medical Assistance for Employed Persons with Disabilities, impact your ability to work, and what does access to this program mean to you?
Thank you, Lisa, and good afternoon, everyone. My name is Brittany Hernandez-Wilson. I'm so grateful to be here today. For a visual description, I am a Black and Mexican woman with shoulder-length, dark brown curly hair. I'm wearing a dark orange sweater, and I'm sitting in my electric wheelchair. It's hard for me to put in words how much this program has meant to me and the incredible impact that it's had on my life. I still remember the day that I found out about MAEPD and how during the call, I could feel weight being lifted off of my shoulders. I learned that I would be allowed to earn competitive wages while still having access to the services that were only available to me through Medicaid. I rely on personal care attendants, homemaking services, and more to live in my own home and to participate in my community. And these services aren't available in any other form of healthcare that I would be able to get through my employer. People with significant disabilities like myself often need this type of coverage to be able to work, and Medicaid buy-in programs offer a pathway to do so. This program gives and has given me and others the autonomy and support that we need to be able to live the life that we want. I've been on MAEPD and have been gainfully employed and earning competitive wages for over a decade. And because of that, I have been able to grow as a professional and pursue my dreams, including moving away from my family, living, where I want and where I feel most safe and comfortable. I also have a much more vibrant sense of belonging and purpose because I'm able to work pursuing my passions. And another point that I wanted to make is around impact are that these types of programs have a much broader reach than just the folks who access them. When people with disabilities are employed, our entire workforce is stronger because of it. The diverse perspectives that we bring to the workforce allows for a greater understanding of each other. It challenges people's perceptions of what is possible, which can lead to opportunities for growth, both internally in the organization and externally. But also it attracts business, and I believe that everyone wins when we're all able to contribute. Simply put, access to this program changes people's lives because it allows people with disabilities to get to the starting line along with everyone else. And it's powerful. It allows us to dream, to be, and to represent. This program is everything, and honestly, my life would not be what it is today without it. Thank you.
Thanks for sharing your personal experience with us, Brittany. Nancy, this next question is going to be for you. What role does Kansas's Medicaid Buy-In for Workers with Disabilities program, called Working Healthy, play in the state's strategy to reduce barriers to employment for individuals with disabilities? And can you tell us about how the program has benefited the state while supporting those employment opportunities for its residents?
Thank you for including me today. I'm a middle-aged woman with short, light brown hair. I'm wearing dark glasses, a black sweater, and a holiday scarf with images of a snowman, Santa, and snowflakes. Kansas has a cadre of well-trained benefits counselors who are located in regional areas and are part of the buy-in program and also state employees. I believe we're one of the only states that offer benefits counseling in this way. They provide support at no cost to individuals who are interested in starting or increasing employment. In addition to individual benefits counseling, they also provide outreach presentations and program maintenance to assure members are able to keep their Medicaid coverage. This counseling provides an informed choice to individuals, and many times they choose employment over often more expensive waiver services. We were lucky to have evaluation outcomes, despite the fact that they were from 2011, to assist us in the approval of an 1115 demonstration project. This innovative and voluntary project was designed to offer supports and training to individuals to achieve and maintain employment. The program was implemented in 2021, and we already have some really good results. Many of our program enrollees come from the intellectual developmental disability wait list, which in Kansas is long, and services under that waiver would be more expensive to the state than participation in this demonstration program. We also have a strong presence in other state initiatives along with advocates, and currently have we have a strong presence in other state initiatives that impact employment of people with disabilities. Some examples are, we drove the Employment First initiative along with advocates that assist us, and we currently have a presence with the Commission. We fully participate in the Kansas Disability Caucus, which brings together Kansans with disabilities to create a legislative agenda in Kansas. And we also participate in transition initiatives, and we work closely with Kansas Department of Education.
Thanks, Nancy. Our panelists have now outlined how Medicaid Buy-In for Workers with Disabilities programs reduce barriers to employment for people with disabilities. However, as BPC's new report notes, there are challenges for states adopting or optimizing these programs. So now let's explore some of these challenges. This first question will be for Annette. Annette, states have options to modify their Medicaid Buy-In for Workers with Disabilities programs, but there is minimal updated federal guidance explaining these options. Can you discuss some examples of states' options for modifying their programs and how inadequate federal guidance on these options can hinder some states from adopting or optimizing these programs?
Sure, thank you. Yes, I am for my description, I am a middle-aged Caucasian female with light shoulder-length hair, wearing glasses and a dark blue top. States do have many options when seeking to modify or improve their Medicaid buy-in for workers with disabilities, but they are unclear on the rules regarding increasing or eliminating income and asset limits to support individuals' employment goals and allowing for higher expectations for those on career paths, how to remove the age limit of 64, and what the options are for the treatment of income for those who experienced earnings and employment success while enrolled in the Medicaid buy-in for workers with disabilities, but still need Medicaid when they can no longer work. States want the option of allowing for a time-limited continuous coverage during an interruption in employment for medical reasons or job loss for reasons out of the individual's control. Some states have dedicated time and resources to developing plans for changes, including legislation, only to find out after submitting their request to CMS that what they were envisioning is not permissible under federal rules. This not only impacts the lives states intend to target, but it also causes tension between the disability community and state and federal officials. Sometimes the concern about the unknown causes hesitation or even reluctance to move forward with programmatic improvements. Even the nickname Medicaid Buy-In causes confusion because it is not called that within the MACPRO system CMS uses for states to amend and operate their Medicaid programs, or even within each state often. And in fact, the term Medicaid Buy-In is more recently used for a different eligibility group unrelated to Medicaid Buy-In for workers with disabilities.
Good points, Annette. This next question now is going to be for Nancy. BPC learned from its interviews with states that there's limited federal technical assistance, including state-to-state learning opportunities on the Medicaid Buy-In for Workers with Disabilities program. At the state level, what challenges does this limited technical assistance and lack of state-to-state learning opportunities pose for states implementing Medicaid Buy-In for Workers with Disabilities program?
When Kansas designed and implemented the buy-in program in 2002, it was a very new idea, and we were operating in a confusing environment with very limited knowledge. The grant funding provided gave us an opportunity to gain technical assistance from 2 technical assistance providers, and we used both of them. This gave us some expertise when we needed it, opportunities to meet regularly with other states and with CMS experts to share information. Since the grant ended in 2011, we have had very little contact with other state buy-in programs and very limited guidance from CMS when we have questions. Would like to see grant funding used for states to have technical assistance to successfully navigate the design and implementation of a buy-in program. Funding is also important for current states to fully evaluate their programs and opportunities to share information with other states so they can improve their current programs and create some new innovative opportunities. We don't have current information on employment of people with disabilities in states. The most current Kansas buy-in data is from a 2011 report, and even though it's dated, it really helped us to gain approval for an innovative new program. The data we used from our past grant funding indicated that continuous enrollment in the buy-in for Kansas with disabilities created a pathway for increased individual state tax revenue and for decreased Medicaid expenditures. People in this program also reported a better quality of life when they were employed. And finally, while CMS and Medicaid buy-ins may not be able to affect the Social Security system, I just want to note that a disability determination is still built on the ability not to work. As soon as you're determined disabled by Social Security, we in the buy-in world say, now you're ready to go to work and not lose your Medicaid benefits. It's confusing. So many changes, yet we still have an archaic system to prove that you can't work and then will be funded for life, instead of what do you need to go to work?
Great points, Nancy. That brings me to my next question, which is for Brittany. DPC also learned that there is minimal consumer education on the program, including inadequate cross-agency coordination to support outreach for the program. How does minimal consumer education reduce beneficiaries' access to the Medicaid buy-in programs? And how is limited cross-agency coordination contributing to this challenge?
Minimal consumer education can have grave effects on accessing these life-saving programs. Often, if you don't know the right way to ask a question, or maybe you're not sure of how to exactly to advocate for what you're needing, you can be left to figure out things on your own. Getting onto these programs and maintaining eligibility is a complicated process to navigate. If you don't have a doctor who can provide the documentation you need or access to transportation to get to different places, if you don't have a computer or technology to apply for the programs, barriers like having English, just the level of understanding that is really required to understand even the lingo that's used on the forms can cause people to get stuck and stalled. And states don't know enough about the program to really structure it and manage it well. I had started working at the age of 16. Every year I had a reassessment, and I was working and earning some wages from that age. Yet every year, no social worker, case manager, or anyone really told me about this program. And because people with disabilities can rely on these types of services to live, people in these systems are really forced to choose between the impossible. And once you're, approved to be on these services, there are some challenges that can come with just being state enrolled on them. For example, my Minnesota requires you to also apply for Medicare, and because I was duly eligible, I ended up being notified that I'd actually have to pay for my state premiums and Medicare Part A and B, and that was a lot of money. It really came to a point where I had to make a decision. Am I going to, continue to work, or will I have to be forced to quit? And that can be very, very challenging. And states don't have enough of an understanding of these programs to really be able to communicate it in ways that we understand. There was really no follow-up once I got enrolled on MAEPD. It was really up to me to stay up to date with the mail and to make the calls that I needed to. And because there were eligibility requirements in my particular eligibility status, eventually I got to someone that was able to help me with all of the premiums that I was paying, and I was finally able to actually stay on that program. But honestly, I almost lost everything, and that is a very scary place to navigate. And so there is a lot of work that can be done to increase education across the board, and for agencies to really speak together so that consumers aren't forced to go here to find one answer, go there to find another answer, piece together. It can be very challenging. Thank you.
Great point. Thanks for sharing that, Brittany. This next question is going to be for Henry. Henry, there's limited data collection, analysis, and research on the Medicaid Buy-In for Workers with Disabilities programs, hindering stakeholders' ability to monitor and evaluate the programs. For example, there's no updated federally published enrollment or service utilization data, and there's no data disaggregated by race or ethnicity. How does this limited data on Medicaid Buy-In for Workers with Disabilities programs pose a challenge to evaluating and really optimizing these programs?
Thanks, Lisa, for the question. Unfortunately, it's a real challenge. Not only do we lack data here, we lack data on people with disabilities broadly. It's a longstanding problem that needs attention. And it speaks directly to the experience of people with disabilities, not just the Medicaid program and its relationship to work. The lack of data makes it difficult to generalize about the experience of people with disability and hinders our ability to design programs accordingly. The lack of data also complicates our ability to understand how these programs might be used to address some of the inequities that are experienced by people that rely on the program. We need better demographic data if we're going to be able to understand how Medicaid might be used to address some of the historic inequities that are based on race, ethnicity, and disability as well. However, the Medicaid program does have some data reporting requirements and offer financial incentives to states to report on broader aspects of program participation. These limited data collection activities are often largely tied to the fiscal integrity of the Medicaid program. And the incentives that I mentioned are often used to gather more and better data, to develop a better understanding of how to optimize the design of these healthcare and related services programs that serve certain covered populations in the Medicaid, that rely on Medicaid. Since employment status has not been tied directly to the role of the Medicaid program, CMS has not claimed any meaningful orientation towards the employment aspirations of people with disabilities. Further complicating matters, a majority of the general public, I think, still believe that the population that rely on this program may be in some way unemployable. So we have lots to challenge there. And without better data, it's really difficult to develop those arguments in ways that can inform and influence policy. Again, outside of the limited technical assistance that's available at CMS right now on the Medicaid eligibility groups, states don't really have a place to turn to learn more about how the program works. And so they're often relying on states to share information about their program design, use that to inform the goals that they're pursuing with their Medicaid program within the state. And this kind of loose-knit information sharing really is something that could both enhance our access to data and give us a clearer picture about that experience of disabled people seeking work and the role that Medicaid plays. So we'll talk maybe a little more about the Technical Assistance Center that's called for in the report later. But I think the center, the Technical Assistance Center, is essential to fostering and optimizing the design of state Medicaid buy-in programs. And with that, I'll turn it back to you, Lisa.
Thank you, Henry. So our panelists have just outlined three primary challenges with Medicaid buy-in for workers with disabilities programs. The first being inadequate federal guidance on states' options for designing their programs. The second being a lack of clear, consistent, and accessible consumer information on these programs. And third, limited technical assistance and data collection to assist states with identifying and optimizing some promising state practices related to these programs. And now I want to turn next to exploring some of BPC's federal policy recommendations to address those challenges. But before we dive into that, I do want to remind our audience that you may submit questions using live chat on YouTube or on Twitter by using hashtag BPCLive. All right, this next question now is for Annette. Annette, you spoke about how inadequate federal guidance on states' options for designing their programs restricts some states from adopting or optimizing their programs. And BPC's report recommends that Congress direct CMS to publish guidance and undergo formal rulemaking to help states adopt and optimize these programs. Why is it necessary for the federal government to both publish guidance and undergo formal rulemaking? And what are some examples of the topics that should be included in the guidance?
Sure. Thank you for the question, Lisa. From 1997 to 2000, CMS released 4 state Medicaid director letters providing guidance on the Balanced Budget Act and Ticket to Work authorities. Since then, many things have changed, not just with healthcare, but also among the country's workforce in improving equitable access to the full breadth of community living for people with disabilities of all ages. State Medicaid director letters are valuable resources which clarify and communicate Medicaid policies. With those introductory resources, along with Medicaid infrastructure grant funding to states at the time, more states adopted the group within their Medicaid programs. The intention was to codify the group in federal regulation. Over the past several years, competing priorities, including broader Medicaid transformation activities, have delayed codifying the group. The lack of formal guidance, in combination with inaction to codify the groups in regulation, have caused concern among those in the disability communities, wondering whether the groups are at risk. In addition to making the groups a more permanent part of Medicaid, along with other Medicaid eligibility groups, CMS Notice of Proposed Rulemaking would solicit and consider public comments, including from individuals with disabilities who want to work and those who provide support to them as it issues a final rule. This process would also provide CMS with broader insight into state activities and where there could be flexibilities for states. The regulatory process is often lengthy and requires considerable CMS resources. State Medicaid director letters also require CMS resources, but could clarify and cover topics at a high level in a shorter time frame in advance of rulemaking. Almost every state Medicaid program provides some sort of employment support service to individuals with disabilities who want to work. Even services supporting successful community living do so in the spirit of full inclusion, with a person-centered approach and individual choice. There are state and federal efforts to employ workers with disabilities and increase opportunities for fair wages and employment for people with disabilities. Formal guidance would provide the resources and tools states need to support those individuals who achieve successful employment as a result of those efforts. Over the past few years, CMS has released guidance which supports states' efforts for Medicaid members in need of access to home and community-based services. This includes new flexibilities allowing for health-related social needs to support better health outcomes. It is an exciting time for Medicaid, and it's an ideal opportunity for workers with disabilities who need services only offered by Medicaid. Thank you.
Thanks for that helpful explanation, Annette. This next question now will be for Nancy. We learned how limited federal technical assistance can create challenges for states adopting or implementing Medicaid buy-in programs. And BPC's report recommends that Congress establish a National Technical Assistance Center through which CMS can identify and promote promising state practices related to the program. With this Technical Assistance Center, what are some examples of topics the Technical Assistance Center should focus on, and what types of technical assistance would be most helpful for states?
We have some recommendations that we'd like to offer that we believe technical assistance could affect. First, ensuring some expertise at CMS and offering technical assistance to states to bring CMS and states together to find solutions and to identify some common barriers. To assure supports for benefits counseling so that individuals can make an informed decision about employment. This will help bust the myth and reduce the fear that people have of losing all their benefits if they choose to go to work. Expertise to guide states to gain personal assistance programs in ways that are going to encourage independence, safety, and so that people can get the supports they need to be successful with employment goals. Program evaluation so that states can develop a current idea of what is actually happening with employment of people with disabilities in their states, and so states can share results with each other. And finally, to look at standards for buy-in programs. In Kansas, we see a need to set some income requirements, and we really struggled with this. How do we best assure a person's intent to work and maintain their employment? How do we demonstrate that people are working on their employment goals? We believe this was very important for program integrity.
Thank you, Nancy. This next question now is for Henry. To assist states with building or improving their capacity to sustain Medicaid buy-in for workers with disabilities programs, BPC's report also recommends that Congress establish an 8-year grant program that builds off of the lessons learned from the previous Medicaid Infrastructure Grant, or MIG program. Henry, can you provide some background on how the MIG program previously supported Medicaid buy-in for workers with disabilities programs, and how BPC's proposed grant builds upon those lessons learned from the MIG?
Sure, Lisa, thanks. First, for background, the Medicaid infrastructure grants in the Ticket to Work and Work Incentive Improvement Act came in at $500 million. And so it was quite substantial funding. And the areas in which the funding was generally available included the following: developing Medicaid infrastructure by facilitating targeted improvements to the state's Medicaid program and developing a comprehensive employment infrastructure that coordinates disparate state service delivery systems. 2, removing barriers to employment of people with disabilities by creating systemic change throughout the Medicaid program and coordinating with other programs to further barrier removal. And finally, the general area was developing infrastructure that offers sustainable and significant improvement in the ability of the system to provide adequate healthcare coverage, personal assistance, and other supports for people with disabilities who are competitively employed. So that was quite ambitious. The barriers to employment for this population are numerous, and it's reflected in those criteria. At the same time, they had MIG funding for over 10 years. And we learned that many of these barriers are deeply rooted in systemic issues that require a major shift in societal's view about the capabilities of disabled people. Some of the programmatic reforms that would promote employment for disabled people are carried out now by federal partners like the Office of Disability Employment Policy at DOL. And these issues really require sustained attention to lead to change. Employers and decision makers about hiring are often viewing people with disabilities as a challenging population to bring into their workforce. And again, much work needs to be done there. So the new grant program really needs to sharpen its focus. And from what we've learned from Brittany, when you actually are working and you don't know that there is a Medicaid buy-in program that's available to you, it's real evidence that we don't give enough information to disabled Medicaid beneficiaries about the existence of these programs. We need people like Brittany to know that this is possible. And so these MIG grants really have to develop a very sharp focus on making sure that the type of information is out there and promoted broadly about the Medicaid buy-in program so that people don't have to be attached to a certain system just to get information about the program's existence. The funding in this MIG program that's outlined in the report is limited to 8 years, and it phases out towards the end of the funding cycle. And as I said, we learned in the Medicaid infrastructure grants from the previous round that these are longstanding problems, and the result of just ending that funding resulted in abrupt gap in information. And we basically found that there was little information about the Medicaid buy-in program that was generally available at the end of the MIG grants. So there's a real problem that needs a very specific focus. And we hope that the MIG grants in this new report would be focused on that. In addition, you heard from Nancy about the critical role that benefits counseling plays in allowing people to kind of shape their decisions or shape their future and make decisions about how they want to live their lives. We really don't have good examples of benefits counseling programs that are funded at the federal government. And so part of the challenge here is going to be for these MIG grants to make sure that they have sustainability components built in that address both the benefits counseling that I just mentioned and the need to maintain awareness of the availability of a Medicaid buy-in program for working disabled people so that they can turn to it to retain their much needed Medicaid services when they want to work. And finally, I'd mentioned that there's likely to be an interesting interplay between the Technical Assistance Center and these re-envisioned MIG grants. It would help, with the state experience, it will help optimize the design. We've mentioned that in the past, but I think it can also innovate the design structure of a Medicaid buy-in. Remember, the needs of people with intellectual and developmental disabilities may differ from those with physical disabilities. And the peer supports that are needed by people with mental health disabilities are often not the same model that would work for the other populations I've just mentioned. And so there's, to some extent, these approaches need to be tailored, but at the same time, the Medicaid buy-in program needs to be general enough to serve all the populations. And that's a challenge that the MIG grant could also take on. And finally, another piece that I think it's important to mention is that we're finding that many disabled people need to continue to stay attached to the program and maintain their eligibility past age 65, or what people would consider traditional retirement. And so the needs of that group will vary perhaps slightly or significantly from some of these other populations. And program design for the Medicaid buy-in needs to take into account a number of these considerations. And with that, I think I can turn it back to Lisa.
Thanks for that explanation, Henry. This final question, before we turn to audience questions, is for Brittany. Brittany, you previously discussed some of the challenges associated with the lack of clear, consistent, and accessible consumer information on the programs. As Henry mentioned, BPC's proposed grant program requires grantees to use the funds more narrowly to support consumer outreach and benefits counseling in the final 3 years of the grant. Why is it important to focus funding on consumer outreach and benefits counseling? And how could this funding help address disparities in employment opportunities for individuals with disabilities?
Thank you, Lisa. I think it's important to focus funding on outreach and benefits counseling so that people with disabilities can make the best decisions about our lives. As you've learned throughout this and heard, these programs have a big impact on our lives, and there's so much to be done to ensure that more people know about them. We've heard about the high disparities of people with disabilities who want to work between those who are actually given the opportunity to do so. And I think part of that is because there's this stigma that's very real about working and being able to keep your benefits. Many of us throughout our lives get the message that we can't do both. And that's really just not true, as we've seen today. And so consumer education is a big deal. Information being offered in multiple languages is also a big deal, in culturally competent ways, right? And making sure that things are in plain language are so critical to getting this information out. And then I also think about the process and how we offer supports and services during the actual process of getting on these, right? How are we making sure that if people need accommodations organizations that those are being done. I have friends who have more invisible disabilities, and the way that we talk about how we have to access these programs is much different. And so I'd like to see more outreach done to people of all different types as well of disabilities. And then, of course, there's attitudinal barriers too. Fighting to prove that we can work is a continual process that feels like it never ends. And in my opinion, it's critical that we spend money making sure that people with disabilities do receive that right info. Benefits counseling and outreach can also make sure that people know that the program is available, and then also can help us understand how to manage our benefits. And part of that is knowing the rules, right? And understanding those rules is foundational to knowing how to manage our benefits. But we also need folks who are truly understand the systems and who to do the work and know what these programs are so that they can explain it to us easily. And as we've heard, we just aren't learning enough about these programs or how to manage them. And funding could help address disparities in employment opportunities for people. And a good place to start is through that benefits counseling, which would help start to address some of those disparities. And through funding, we can start to turn the tide a bit. We are on our way. Many people like myself have used these programs and have, thrived because of this. And we also know where some of these barriers are. So we know that if we don't do this work now, then we're not going to be able to solve these problems. One of the most powerful parts of people with disabilities working is what that means and signals to younger generations who are searching for their world to find folks who look like them. And funding this means that future generations will have that role model. And just speaking from that personal experience, again, I can't tell you how important and how critical it is being young and knowing that there's a pathway for you, being young and seeing someone like that, like you, that's successful, that's living their dreams. It really does. And I can't really emphasize this enough. It does allow you to dream. And that can mean everything when you're a little kid with a disability who feels like you're so alone in this world. So thank you again for having me be a part of this.
Great points, Brittany. We have a few minutes left, and we'll now open up the discussion to audience questions. And this first audience question, I'll open up to all the panelists. And the question is, how do states modify their Medicaid buy-in for workers with disabilities programs? And how could CMS improve this process? Anybody want to jump in?
I can jump in. States submit state plan amendments to CMS, and they answer a series of questions within the MAC-PRO system, identifying the group that they wish to make changes to, and then there's a series of prompts and questions. The tricky part for states is that it's called Work Incentives Group for the BBA group. It's called Ticket to Work for the other group, and Ticket to Work Medically Improved that Henry alluded to. In the MAC-PRO system, it's not called Medicaid Buy-In. And so states submit state plan amendments to make those changes. But there's a lot that needs to be done in preparation for that submission, including knowing whether or not you're ready, your systems are ready, your training has happened for eligibility workers, you have the capacity, your infrastructure. And that requires a lot of state and federal coordination and effort. So there are materials on the web, but I don't know that, and that's for the MAC-PRO system, but I'm not sure everybody is aware of those, and they're not necessarily as user-friendly as perhaps they could be. So additional materials, guidance from CMS, and really technical assistance that we've spoken about would be critical across the board.
Thank you so much, Annette. It looks like we only have about 2 minutes left, so we're going to go ahead and wrap up. And I just want to say a big thank you to each of our panelists, to all of our viewers out there, and to the Robert Wood Johnson Foundation for their generous support of this work. If today's discussion piqued your interest, please check out BPC's website for our new report titled Next Steps, Improving the Medicaid Buy-In for Workers with Disabilities. Thank you again, and take care, everyone.
Thank you.